So I've got one more thing if we can hang on here. Hopefully we've enjoyed it. I'd like to close it out with a couple of points. And here we go. Again, my disclosure. So I've done a lot of work on hybrids, and this stress point medially was one of my big concerns. The soft bone questions that we've heard, the knot tying questions that we've heard, I've heard that from all the surgeons, so I was trying to solve that. If you look down here at low, Sano and Itoy have shown that the stress riser medially is eliminated by Transosseous. So that's going to be your salvage of the type 2 failure. So that's been shown in those studies. You know, Dr. Rodeo and Shukumaran have all shown us that everyone was talking about single and double row, and there was no difference, and no one was controlling for suture number, which is the really important thing. And now that we can do repairs with a lot of suture in them arthroscopically fast, you know, very fast in the OR, where we're back to this concept that I really want to emphasize, which is we want high fixation point density per surface area for load sharing, and number of sutures per fixation point. That is what is important in terms of strength. And this is probably the most ignored study, you know, in the literature by Gus Mazzacca and Bernie Bach, and these guys are not slouches when it comes to research. On the right, you'll see this is Dr. Cole's slide at the ESH meeting showing 350 to 400 newtons with Transosseous equivalent. Look on the left, the multi-suture technique, which is done like this in the lab, was 856 newtons ultimate failures, higher than an intact cuff. They were actually ripping the surgical neck off the specimens. So this, you know, we can do this transosseuously now if you want to. You don't have to, but again, that's that ceiling that Dr. Shukumaran was talking about. This was the first hybrid I did in practice. We looked this up in AJSM 2007. Hybrids are there. This one had 400 to 500 newtons, very strong failure. So again, we're just trying to optimize the variables of time, cost, fixation, and usability. And what's the best mixture of that? You know, how fast do you want to go? Is that what you want to go for? Or do you want to go for biology, or do you want to go for cost? All of us have different personalities there. But that's why, that's what led to multiple different techniques that eventually we landed on this true Transosseous hybrid. So this is essentially an X-box repair where you leave the tails long and then bring one anchor down immediately. And so this was meant originally to address the concerns that we've heard about, you know, is there soft bone? So it gives you a fixator if you want it, but not multiple fixators. And it gives you a chance to retension, you know, and have a knotless last step. There's no anchor burden at the footprint, only microfracture, which, as we know, is the only thing that's really been shown to improve healing. It's a triple row, which, if you care about that, it has cortical augmentation, and it's improved cost per you know, multiple fixation points. And it's a self-reinforcing construct, just like a Transosseous equivalent repair with anchors. So this is what it looks like from posteriorly. It looks just like a Transosseous equivalent with anchors, except there's no anchors. And it just has one anchor laterally. There's no anchors in the healing zone. And here's one from laterally with tapes and an anchor. And again, echo other panelists, tapes, anchors, when you use all these together, you're really probably superseding what you're seeing with some of these other techniques that are anchors only. These are my results of my first pilot study, 143 patients over 14 months, 5% re-tear with Transosseous, 4% with the hybrid, over 40-point increase in ASES scores. And I saw more pain and decreased ASES scores in the anchors. You've seen that in some of the literature as well. I would like to show how the tunneler is deployed and how fast it can be. So here's the technique. We clean out the lateral gutter. Here's the device, one-handed operation. We go in inverted, we pop through the subdeltoid fascia, and then we rotate up to the hole, 2-9 hole, which has been made medially with an awl, just like you would for an anchor. We pop in there and rotate as far down as we can. We can get about an 18 millimeter, maybe a 2 centimeter bridge there if you can rotate down. Just one mallet in and back out with an assistant. It stays in place by itself. You can let it go if you want. And then we're done. So it's just a little over 20 seconds, and that's the equivalent of 2 anchors that just went in there. So it's 2 fixation points. And then we pull out the managing suture medially and pass our triplet. So 3 sutures for me is the optimal number for efficiency and strength balance. We pull the triplet through. So the triplet, for me, is the functional moiety of cuff repair. And then we manage these sutures topographically. So the anterior sutures on the skin are anterior inside the suture, inside the shoulder. We use colored roach clips, my team calls them. And they're clipped statically down below and dynamically up to the drape. And so we do that on both tunnels. That's what they look like, very similar to anchors. And then this is a key step. We take the cannula and exclude the sutures inferiorly. So this makes the repair exactly like an anchor repair. So you can manage the sutures exactly like an anchor repair. So you pass those sutures, and then here we're gonna bridge the tunnels. So we're gonna make our mattress suture, and Dr. Lazarus, I believe, was doing this the same way, shuttling them. In this case, we're gonna leave the knot on top, but we're gonna bring it down at the end of the case. So some people had concerns about tying knots, so we tie this extracorporeally outside the body and then pull it back in. You can see this on arthroscopy techniques. I won't go through the whole thing, but we'll tie this simple, and I'll show you. You can pull the knot stack where you want it to maximize shear and compression. So you can't do that with anchors. You can put the knot where you need it to maximize whatever you're trying to achieve. And here it is when we're done from posteriorly. So we bring these anchors down, one anchor down, and interlock below the lowest limb there. So it's self-reinforcing and it interlocks itself. So that's a 5 fixation point repair with 1 anchor. So that's a force multiplier. And I think we can have kits where we can have an anchor and use it, and I'm not against that. Sometimes you want the best of both worlds, but we need to do this with biologics as well. So my pearls would be low portal placement, topographic suture management, and suture stabilization with the cannula. This single row repair is excellent. I think that may be better than anchors. Here's a single tendon. I use an X box and a racking hitch here. And then for the big ones, we use 3 or 4 tunnels, usually 3, and similar to Dr. Lazarus there. Or that's all transosseous or a hybrid. So you can do that, leave the tails long, and then bring 1 anchor down if you desire it for some reason clinically. And again, this single anchor cuff up here, that's Mason Allen sutures with 2 simples. I can't make a single anchor look like that. So that may actually, be good there. We had questions about bone mineral density. It's a Gaussian distribution, and above on the top, all fixations work, so it's dealer's choice. There's nothing to worry about. Down below, everything fails, and the ramification of a suture cutting through is much less than an anchor pulling out. And here is where I think about hybrids or potentially augmentation, where you might want to throw an augment in there. And you can see from the nomogram on the right that most of the osteopenia starts around 75 in the females. So there's a ton of cuff repairs between 40 and 75 that can be performed. One thing that accounts for, I was on a panel recently in July with the Transosseous Academy, and we were talking about, and all the panelists said, I have 1 or 2 cutouts a year. And I think that's indications. The 85-year-old female with butterbone who has an irreparable tear gets a reverse now. So I think that's changed the game in terms of the number of suture cut-throughs. We have a lot of different options to treat cuffs. And there's also some device-related things about the way we do it, where we don't drill and we compact the bone tunnels, so we make them stronger instead of removing bone to deal with that. I'll show you some soft bone case pearls here. This is one of the softest ones we ever did, and the awl was able to be pushed in, and I was able to actually push the ablator head just directly into the bone. It was that soft. He actually ripped in the top picture, he ripped the cortex off of the tuberosity there. So this is a huge, 18, 2 centimeter, 20 millimeter defect that you'd have to stack anchors or graft. And so what we did was tunnel through that with 2 tunnels and then use an ACL button, and then anchors around that. I call that an anchor bounded technique. So you can spread out and load share, increase your fixation point density, and think about a technique like this. And this is what it looks like on the x-ray. This guy had an ETOH problem and fell after surgery. And you can see he tried to fracture the tuberosity, but it held. Here's another augmentation strategy. These are commercially available peak cortical suspensory devices. And again, I would challenge you to say that that's not approximating a very strong anchor repair with very good biology medial, no anchors medially. Here's another new technology. We had a question about resorbability, and so this is a massive reverse L-shaped tear that we fixed with Transosseous technique and absorbable buttons on the cuff and on the bone. So we're solving both sides of the problem there with new technology. And this is probably the major advantage of the cost ceiling effect of reducing the cost, is that we can actually legitimately bring in new technologies and utilize them together, even separate from the bundle issue. But you can also use tapes, screws. We've used cement, bioabsorbable cement, and some magnesium or calcium phosphate cement. So there's a lot of different ways to go here. Here's the video of that one, multi-fixation point. That was 6 fixation points, I believe. Excellent articular reconstruction here. And again, the biceps, we don't want to forget about that. So here's a real-time biceps tunnel with the arm forward flexed. I like to interlock the sutures perpendicular to each other. We don't drill, so I feel really confident, bringing the awl through these, splitting the uprights here. We just observe that. You can do this around anchors too, and you can scythe past them very easily. Here you're passing the suture, and then it's passively retrieved intraosseously. And then you don't have to worry about any actuation of any nitinol wires or anything. You just pull it out. So there we are, we're done. And you can get a very nice fixation here in the hardest bone of the humerus. So this is my technique for this. You can see in the top corners, there's a lot of different ways we've used to capture the biceps, sort of like an ACL graft intraarticularly. And the older version of this just came out in Arthroscopy Techniques if you're interested, but here's a hybrid. That is 3 tunnel, so 6 fixation points plus an anchor, that's 7, and then 8, 9, 10, 11 there in the front. So 11 fixation points. Just a bit about outcomes. We didn't mention many outcomes, but there are, the studies that are available have great outcomes and very high ASES scores. And decreased cost and level 1 evidence of decreased pain. We've got this 12 to 18-year follow-up out of Herbert Resch's patients with a mean ASES of 92 at 12 to 18 years. It's amazing results, very high repair integrity for this long. So I think we can extrapolate that. So to go back to the common themes, we've got equivalent outcomes and biomechanics, less type 2 failures, less pain, decreased cost, improved biology and revision considerations, better MRI healing characteristics with Transosseous, and ability, and the sky's the limit in terms of future technologies with synergies with the multi-fixation point within a case that you can achieve with Transosseous. So I would implore you to try to maximize outcome and minimize costs. So with that, unless there's any other questions, I appreciate your attention. We're pretty close to being on time here. If anybody has any questions, you can contact me below. We thank you for your attention tonight. And don't hesitate to send us any questions online or by email. Any other panelists have anything to add?
When you guys do your posterior, like Mark, when you go to 4 tunnels, are you putting your tunneler in through your posterolateral portal? And Brett, what about you as well? I mean, are you going in through a different, or can you go pop all from your anterolateral?
I go all from the anterolateral tunnel, just progressively internally rotating the arm. And,
okay.
And I've done 5. So I've done 5, which was a chore and a half.
Now, like the one thing I get is like I worry sometimes. I guess maybe like when I'm doing it, I need to make sure when I start the front, I need to be externally rotated and really get the tunneler far forward, because if you're not careful, you'll get crowded laterally.
Yeah,
Are you a lateral scoper or a beach chair guy?
I'm a beach chair guy, and that's one of the advantages, is that you can just progress very easy to just progressively rotate the arm as you go. But
Now,
that's the advantage of tunneling. Just for the anchor people, there's no minimum distance medially. Right, that's the beauty. Anchors, you have a minimum distance, on the medial side off the articular margin. There's no minimal distance. You could put them all in a single hole. Doesn't matter. But what you do need is you need a minimum distance laterally for your horizontal mattresses.
Gotcha. And then when you do that, you're rotating. I know you said, for me, like I have to bring the arm down to make sure that I can get my awe medial enough, like on the footprint. But how far out do you bring it when you? I always try to drop my hand down, as far as I can laterally to get that. But how far are you abducting the arm to get even more lateral? And Brad, I don't know if you do that, or Uma or Brad.
I definitely abduct. I don't try to go, I don't do it dramatically, but I'm definitely conscientious more of where my lateral tunnel is going to be as I start maybe a 3 tunnel repair. I don't want to cheat myself posteriorly. Sometimes if you start too far posterior with your first tunnel, which is the anterior tunnel, as you work toward the back, your last tunnel may fall off of the back of the crescent shape of the rotator cuff tear. So on occasion, you'll get a loop of suture that goes over the back edge of the crescent. Not the worst thing, but you want to be careful about the convergence on the lateral side. So I definitely agree with starting a bit more anterior with the first tunnel, so that leaves you plenty of room, and be very conscientious, especially in soft bone, about the distance between the exit points on the lateral side. Spend some time debriding out that gutter, remove the synovial tissue there, make sure you have a clear view. Make sure you use a high posterior lateral viewing portal so that you can look around the corner. I think a room with a view with that additional portal in the back is really critical to being able to see down through the gutter and making sure that you can start anteriorly with excellent visualization. Dr. Snyder was commenting about working on an Alex model, and I don't think Dr. Snyder needs to work on an Alex model, quite frankly, but I think the key issue with that, if I was talking to Dr. Snyder about the technique, it would be, just be very conscientious about convergence on the lateral side. Mark, that 5 tunnel repair, I'd love to see the pictures of that. 4 is the most that I've ever done. 5 is just like, wow.
Was it a subscap?
No, that did not include subscap.
Wow.
That was a supraspinatus, infraspinatus avulsion. We had to figure out, have a plan. What I said before, you had to figure out like what suture to use. We went to number 5 Ethibond because I'd run out of every other type of suture that I could think of, and I wanted something of a different color.
Yeah, you got to have a rainbow. That's the biggest part. That's what I wish they had more colorful sutures.
Yeah. If you sequence properly, I've been stuck in cases where all we have is white today, Dr. Brodigan. It's like, okay, and so I've been in cases where it's all the same color, and as long as you sequence, and I really like Brett's technique. If you sequence properly and use the crochet needle to reach around and grab the proper suture in the proper sequence, and do a little pull test on the sutures, it's doable. The different colors definitely help, but if you follow the steps, it's very doable, even if it was the same color suture.
What about big subscaps?
Not a problem. I just
love them.
Yeah.
They offer the advantage of you don't have to pass double, mattress sutures under the strap muscles. You pass simples. The bone is always hard, and it comes straight back. You can incorporate the biceps simultaneously. So a lot of times I'll do a locking loop on the biceps, and you can with the Transosseous, you can penetrate through the biceps on purpose and just snag it. And it's a 2-for-1. I love those. You can do it intra-articularly as well. What's that?
Will you do 2 tunnels in the lesser, or will you just do 1 tunnel pass forward, do cerclage?
2 tunnels usually, and then sometimes 1 in the interval if there's a big cuff tear, so You know, you can get up to 6 to 9 tunnels and some big 3 tendon tears.
You'll do 2 tunnels in the lesser though?
You can,
Yeah.
yeah.
Yeah, absolutely.
Okay.
So a little abduction, external rotation. Again, that posterior lateral viewing portal is critical. So you have the room with view so that you can look around from the back. You don't have to move your scope around. You still have, you know, you might have to look around for preparation of the lesser, but the tensor is going to come in from the interlateral portal. You're still looking from the back. So right off of that high posterior lateral corner, right off the acromion. So for those of you who only use one portal in the back, if you use like the typical mid-glenohumeral portal in the back, and then you use that same skin incision for your subacromial space, you're cheating yourself. The additional 4 to 5 millimeters from your mid-glenoid posterior viewing portal to the high lateral portal right underneath of the acromion, it makes an enormous difference, and often is the thing that transitions you to being able to do this procedure. So if you're stuck high on the ceiling and you're looking down, you have a room with a view, and you can look around the corner and do the subscap. You can look down through the gutter. You have such an improvement with visualization. It's hard to imagine you get that with a 4 to 5 millimeter difference on the skin side of where the incision is located, but it is dramatic to have that additional posterior portal. And as far as the subscapularis goes, it's really using that posterior viewing portal, abduction, external rotation, and just looking around the corner. And it's very similar to just working through the greater tuberosity at that point.
Okay. All right, next big one, I'm gonna tunnel it.
That's also how Brett does his biceps tenodesis, working through the groove. You know, he's in the same spot, same angle.
Yeah, so I was thinking about your technique, and I was like, you know, because I do a loop and tack, and I can literally do a loop and tack, like where you basically just go around once and then pop it through, and then do like a push lock at the top of the groove. And I've done it in 45 seconds, like literally 45 seconds. But I feel like I could do the same thing with the loop and tack, but just take one limb and pass it through my tunnel, my anterolateral supratunnel, like you do, and just tie it over the top of the cuff, and it's easy. And that's how I do a lot of my, sometimes too, like you guys want like a biceps tenodesis hack, is if you just go to the subacromial space quickly. What I've done, especially in older patients where like you just want to do no anchors whatsoever, like you said, I mean, like we're just trying to, especially Medicare patients, you're trying to minimize costs because your DRG is so low, is with your anterolateral tunnel, if you make it really, really far interiorly, like way almost at the edge of the bicipital groove, just pass 2 or 3 of your sutures through the biceps when it's still attached to the glenoid, and then pass them through the cuff, and then just tie them down. And you'll have 3 to 4 sutures through the biceps tendon, and it's going to stay. I mean, you have 2 to 3 sutures, and then you just cut the biceps, tie your cuff, and boom. And then you literally, that's a 1 second biceps tenodesis. Like, and it's through a tunnel, it stays, they don't come loose. I've done it many, many times. And it is, and by the way, you're tensioning it perfect, right? Because you're passing the sutures through the biceps while it's still attached to the glenoid. You understand what I'm saying?
Yeah, I leave it attached for my technique because it's perfect tension. And then I had a few failures early with very small tendons, and I go back in afterwards and release it with a small piece of labrum that hangs up in the groove. And I've had 0 failures with that. And relating to your SCR, you can use the biceps autograft, leave it attached to the glenoid, and bring it back through a tunnel. You can whip stitch it and use that as like a biologic cheap SCR that's available.
South Koreans have actually published on that and doing like a lot of really crazy stuff where they go way down deep with the biceps, and they've actually had like a quiff fancy ways of snaking the biceps around to make it an SCR. And I know that Jeff Abrams has talked about doing that too. And Rob Bell put that in his book somewhere, Brad. I don't know. Rob Bell used to come to Greenville every single year because he's like Dr. Hawkins' boy. He's just a really, really nice guy, man.
He's the Hawk first fellow, and they're super tight. So, you know, one thing about the biceps tenodesis and why I transitioned to fixing it through the tunnels on the greater tuberosity, Butch Krishnan, who did my biceps, did it that way. And my tenodesis held up well despite non-compliance. You know, I don't have groove pain. I'm concerned a little bit about groove pain. So I started to transition my tenodesis technique to the greater tuberosity and not fixing anything into the groove if I can get away with it. Now, if I need the additional fixation, I'll go to the groove. But if I can fix it to the greater tuberosity with a little bit of additional preparation of the greater tuberosity to give the biceps some room to sit down and allow the cuff to come in over top of it. I don't want the biceps to prevent my cuff from healing, certainly. It's like a soft tissue interposition between the cuff and the bone. So you do have to prepare the greater tuberosity a little bit more. But avoiding the groove does have some advantages for the patient, and I can speak from my own experience. So, and it's a little bit of a learning curve to incorporate the biceps into the same space as your cuff repair. But after you get the steps down, it's really not that much more difficult. And Brett's technique is super solid. So for the guys that are heavy laborers and potentially non-compliant, I think Brett's technique is probably the best technique that I've seen. You know, using that mattress technique and then using the hard bone of the groove. You know, his tenodesis fixation isn't going anywhere. So I think having options is fantastic, and this device gives you those options.
Yeah, for sure.
Awesome. Well, great webinar, guys. Thanks so much for participation. All the attendees, thanks a lot for sharing your time with us. Anybody who wants a copy, email me. We'll send you one, and let's look forward to another one in the future.
Thanks, Brett. This was great. Great job organizing it.
Yes, I totally agree. Thank you for inviting me.
Good stuff, man.
Take care, guys.
Very welcome. Y'all take
You guys-
care.
Later.